start the recording. All right. Hi, everyone. Welcome to this webinar on visual reporting in the health and social care sector. It's really nice to see a big crowd to want to hear about this. First, shortly introduction of myself. I'm Emil Ackerman, currently the chairman of the board in Tietojohtamisen Verkosto Association, which is a Finnish non-profit association focusing on the dissemination of best practices regarding health and social care related knowledge management. As my day job, I work as the Chief Data Officer at the Wellbeing Services County of Pirkanmaa in Finland, and I'm also an alumni of the Young Executive Leader Program organized by the International Hospital Federation. This webinar itself is organized in cooperation with Tietojohtamisen Verkosto Association and the International Hospital Federation that you will hear a bit more about soon. About the agenda for today, we have three very interesting presentations on data visualization and visual reporting. The organizations that will present are Wellbeing Services County of Pirkanmaa from Finland, then Karolinska University Hospital from Sweden, and Northwell Health from the USA. So it's a very interesting program, but before starting with the presentations, I would like to ask the CEO of International Hospital Federation, Ronald Lavater, to say a few words about the organization and its role in bringing healthcare professionals together from all around the world. Ronald, the floor is yours.
Well, thank you, Amal, and thank you for everyone who is attending this webinar. It's a real honor to say a few words about the International Hospital Federation and then really let you get into this very interesting program. The International Hospital Federation has been around for more than 90 years, and we have members across the globe. We have 150 member organizations across the globe, like in Finland as a full member, or Karolinska is also a member, and Northwell through the American Hospital Association is a member of the IHF. And through our members, we have connections to over 25,000 hospitals globally. And what IHF is committed to doing, what our core foundation is knowledge exchange and helping hospital leaders and hospital administrators across the globe become better at what they're doing. And by having better hospital leaders and hospital administrators, it improves the health at the community level. And that is our core mission. So we're super honored and excited to be part of this. And as you heard, we have a program called the Young Executive Leadership Program. And we look for talented hospital leaders that are 40-year-olds or less. So we want the young folks that are going to move up in their organizations to join our Young Executive Leader Program. And we're actually looking for candidates right now for the 2024 edition. So if you're an IHF member, look for the application. You can go online and submit your application. It's a great program, and we're really proud of it. So I will turn it over back to your host, and thank you everyone for participating in this valuable session. I cannot wait to hear about the best practices on visualizing health reports. As a former hospital leader, it's so important to get the message across because we can be inundated with information, but being able to act on it and really take an action on it, it's important to understand it, and visualization is part of that. So Amal, back to you.
Thanks, Ron. It's great to have you here. So let's move on to the presentations. And first, we will hear about the visual reporting from Finland in the Wellbeing Services County of Pirkanmaa. And the presenters are my close colleagues, Knowledge Manager Antti Markkola and Development Manager in Knowledge Management, PhD Pia Seppänen. Antti's and Pia's teams together constitute the Knowledge Management unit of the organization. Antti leads the team of 10 people tasked with developing reporting capabilities, while Pia's team works with developing data collection and change management processes related to data utilization in the organization. both the teams cooperate closely with all the internal service departments and various supporting functions, such as the IT department. Antti and Pia, the floor is yours.
Thank you. I'll do a quick sound check. You can hear me?
Yep.
Great. Okay, I'll start the presentation then. So today we are, as the title suggests, we're going to talk about visual reporting in the Wellbeing Services County of Pirkanmaa. A quick warning, this is the first time I'm presenting on these things in English, so I might make up a few words on the go. So if there is anything that's unclear, just ask and I'll try to clarify. So this is a joint presentation by me and Pia. I'll run through the first half and then Pia will continue and finish with her part of the presentation. No. Okay. So what is the Wellbeing Service County of Pirkanmaa? It's quite the official English term is quite a mouthful, and also in Finnish it's quite long, so we abbreviate it to Pirha, and that is the word I'm going to be using in this presentation. So if you hear me talking about Pirha, that refers to the organization. And we started operating in the beginning of this year, so we are almost a 1-year-old organization at the time. This was part of a larger reorganization of healthcare and social services in Finland, and in our area, we replaced 23 municipalities as service organizers in healthcare and social welfare services. And we service the Pirkanmaa area, and there are over 500,000 inhabitants in the area. We have, at the present time, we have over 20,000 employees, and our yearly budget is around 2.6 billion. And on the right side, you can see the map of Finland, and we are located, the blue area constitutes the municipalities that we service, and Tampere is the central city of the area where most of our administration is located, and we are also here. And if you have any, to give some context, Helsinki, the capital, is located on the southern coast, and Santas village is located up in the north at the Arctic Circle. So we're pretty much in the southern part of Finland. And so what is a Wellbeing Services County? As I mentioned, we were formed in a large administrative reform in the beginning of the year. Before that, the healthcare services were split between municipalities and larger hospital districts. And the hospital districts were in charge of emergency care and hospital and clinical services, whereas municipalities were responsible for primary healthcare, social services, maternity clinics and guidance centers, school and student healthcare, and rescue services. And then from the beginning of this year, all these services were amalgamated into these new areas, and we are now a one-stop shop from primary care to very specialized care. So we are probably there when you're born, and we will be there when you die. And these are just part of the services that we are responsible. There are probably many more, and I just had to put the and more in the end, so I will get feedback for forgetting some important part of our services. Our data is very diverse, especially since we were formed from several municipalities with their own IT systems. Our data is scattered across several systems at the moment. We are working on amalgamating them into fewer systems, but that is a long process. But we have started on that track. And also, when assessing our situation, we have several different organizational units which are responsible for their own part of services. For example, hospital services, outpatient services, services for children and adolescents, and so on. And also, of course, we have a different supporting system for finances and human resources, and also location data. And we have also we have to cooperate with the municipalities, since we service the same people in different regards. For example, municipalities are responsible for schools, but we are responsible for the services, health services provided in those schools. And this is as technical as I'm going to get about our architecture regarding service, our reporting. We have our specialized care EHR there is one large system, but it has a lot of supporting systems. Then we have several primary care EHRs at the moment. We are in the process of just moving into a single system in the future. Then we have at the moment also several systems for social services, and then we have the supporting administrative systems. We have an Azure-based data lake in which we collect the data, and we are reporting with Tableau. And this is before showing some examples of the reports and analytics we have created. In Pirha, I just want to quickly touch on one of our goals and key aims where we aim to be. I title Power the People, enable visual analytics at grassroots level. We have a centralized knowledge management department or unit. We haven't settled on the actual English translation yet, so you might see both. And we have expertise in data engineering and creating reports to be utilized in the services production. But we also want to spread the know-how, the knowledge, how to create visual reporting in the service provision, so that the visual reports can be created where they're actually used. And a deep understanding of the function being reported is a key premise for meaningful and useful reports. Was there a comment or a question? No. Okay.
Joo, kyllä
Go ahead, Antti.
Okay. And our centralized knowledge management department worked with the IT department and their subcontractors to ensure that our data lake contains all the relevant data that the people creating reports and using the data can evaluate the services being provided. And our unit cooperates with the end users in defining and prioritizing the data that they actually need. And then we work with the IT department to actually get the data from the systems. And then we support the end users in utilizing the tools for visual analytics, and we participate in creating policies for handling the data. In the EU, we are very, very strict on how patient and customer data is being handled. And now I have a few examples of dashboards that have been created. Unfortunately, they are in my presentation only in Finnish, but I can quickly explain what sort of data they are showing. This slide shows some dashboards where we have combined regional and national data, so we can compare how our county compares to the other counties in the country. And we do not provide all of the data on these reports. Some of them are produced centrally. For example, the Finnish Institute of Health and Welfare is responsible, for example, for the data on prevalence of diseases in different counties and how they differ from one another, and also the costs of services in different counties, how they compare to one another. Another key data, which is very important for us, but is not created by us, is the population information, and that is something that in Finland is updated and produced by the Digital and Population Data Services Agency. I had to read from a note here, and here the reports that are, for example, on the bottom right, it's on population growth, and on population estimates on the change of population in the area. And for example, on the bottom left shows the prevalence of disease, for example, how we compare to other counties. Then we have some reports that have been produced in our unit are executive overviews that are overarching reports that touch on services and information that is relevant to the top level administration. This is our well, in Finnish the translation would be an executive overview. It is updated monthly. Most of the data is automated on this report, but we also have to do some background work on Excel to bring all the relevant information that has been requested. It is split in 3 different categories. There is the services provision information, what is the Net Promoter Score, what are the how many patients are waiting, and so forth. Then we have human resources information, what is the employee Net Promoter Score, how many sick leaves, and so forth. And then there is the financial information for all parts of the organization. Then there is another one which we actually created this month, or at the end of last month. It seemed that the situation with COVID was once again on the rise. So we created this executive overview on various indicators that were relevant in seeing how the hospitals were coping with the increased amount of patients. There are, for example, sorry, I can't remember the word, but how many beds are available at the different wards, and what is the situation in the emergency room. And this was something that was worked in conjunction with our preparedness unit and then our knowledge management unit. And because lastly, there is visual analytics in social services. For in some aspects, social services are similar to healthcare. In those services, we have this example shows how many people are waiting services in different categories, and when looking at, for example, applications, how quickly those have been handled, what is the line, those are quite easily managed in visual reporting. But the trouble we have with social services is that a lot of the data is not quantitative. There is a lot of free-form text, and it has been nationally recognized as something we have to work on improving, how to create more quantitative data in social services. It is a very human-centered service, so finding indicators and correct indicators is sometimes difficult. But in those areas where they are applicable, we utilize visual analytics. And I think that was my part of the presentation, and then I hand it over to Pia.
Okay, thank you so much, Antti. And hello to everybody. It's very nice to see you all in here. I'm going to show you some tabular reports and visual reporting in the University Hospital. And I have 3 examples. And first one is about how to evaluate patient safety, and it's medication safety dashboard. And second one is daily coordination dashboard, and it's about daily management. And last one is how to evaluate nursing quality, and it's about dashboard about pressure ulcers. And next slide, please. And example 1 is medication safety dashboard. And in here you can see 4 different reports, and all these reports updated every 30 minutes. And on top and the left side, you can see patient's home medication, and the time point is admission to the hospital. And in this report, target level is within 12 hours of arriving at the department, at least 50% of the patients have had their medication checked. And in this example, you can see within 4 hours, over 80% home medication is checked. And this medication check can be done by doctors, nurses, or pharmacists. And below you can see 2 reports, and it's about doctor check the patient's medications, and there is 2 time points. First one is admission to the hospital, and in this example you can see the process is doing quite well. And the second time point is out of the hospital. It means patient is going home, or the patient is going to the follow-up treatment. And you can, in this report, you can also see the process is going quite well. And next slide, please. And this is also same report, and you can also make analysis of results of over a longer period. And here you can see 5 months period, and on the top you can see home medication check-up. The results are over 90%, so it's telling us this process is going so well in this unit. And below you can see the doctor check up the patient's medication and those 2 time periods. And in here, in this example, you can see some improvement still needed. Next slide, please. And this is example number 2, and this is daily coordination dashboard. And in our hospital, we have about 60 units using this kind of daily coordination dashboard. And on the top, you can see numbers about patient flow, and this patient flow numbers updated every 30 minutes. And you can see, for example, how many beds are in the unit, how many patients are in the unit, and you can also see numbers, how many patients are coming today and tomorrow, And you can also see how many patients are waiting for transfer to the follow-up treatment and how many patients are going home. There is also one report, it's about the urgency of the treatment. And the deeper blue, 7 patients, it means there is a 7 patients coming urgency. And those light blue, there is a 5 patients, it means non-urgent patients. And you can also see that yellow color, there is a 1 patient, and it means incorrect recording. So this is a kind of recording validation report. If you see yellow color, it means there is something discorrect recording. And below you can see reports about nursing workload, and it means nursing intensity scores. And those reports dated once a day. And in this report you can see 5 days at a time. And the left side there is so nurses have to classify all patients once a day, and we think if the coverage of classify is 90% or more, this data is valid. And there is also a report about patients' need for care, and there is 5 levels. There is a low, moderate, more than moderate, demanding, and extremely demanding patients. And last report is optimal need for care, and it means balance of need for care and resources. And in this example, you can see those 5 red pillars. It means all those 5 days are over optim. So in practice, it means there is a need for care more than resources. Okay, next please. And this is a real action picture. In our units, there are those kind of screens, and all nurses and doctors and other healthcare professional can check in those numbers. Okay, next please. And this is my third and last example about tabular reporting, and this is how to measure nursing quality, and it's about pressure ulcers. And in our hospital, we have a skin and movement assessment, and it must be done of every patient in 8 hours of admissions. And unfortunately, this is in Finnish language, but this is guideline to nurses how to preventing pressure ulcers. And the main point is there is 3 questions. And if you answer 1, 2, or 3 times yes, it's a red line, and it means patient have a high risk about pressure ulcers. If you answer 3 times no, it's a green line, and it means patient have a low risk about pressure ulcers. And about documentation, our nurses using a mobile application, and this mobile application produce the data. Next please, Antti. And here you can see pressure ulcers PU report. And now you may be wondering why this is English language. In our hospital, we of course using Finnish language dashboard, but this is a picture from presentation about this pressure ulcer reporting, which was presented in International Pressure Ulcer Conference a couple of months ago. And here is 3 different reports about pressure ulcers, about how to use assessment, observed pressure ulcers, and hospital-acquired pressure ulcers. Next, please. And here is a report about pressure ulcer risk assessment at the hospital level. And in this report, you can use filters. You can put time frame and the unit. And also there is also report about how many PU risk assessment was made in the selected period. So you can observe whole hospital level or some individual units. And there is also report about PU risk assessment results in different time period. And the last report you can see results from low risk to high net risk. And there you can see low risk 0, and that means three times no answer in that assessment. And there is also 1 yes answer or 2 yes answer and also 3 yes answers. Next, please. And this is a report about hospital-acquired pressure ulcers. And this is very important report because in a good care do not occur any pressure ulcers. And so in here you can see how many hospital-acquired pressure ulcers were arisen at the specific unit, or you can also check hospital level. And you also can see report about description of pressure ulcers in different periods. And there is also number of pressure ulcer stages. And there is a different stages. It means how severe pressure ulcer is. And this report includes also number of mesentery documentation. And last report is number of pressure ulcer at the different units. Thank you.
Thank you. That was our presentation.
All right, thank you very much, Antti and Pia. For me too, there was some new stuff, so I assume that there was a lot of new stuff for the audience as well. There was one question in the message board. It says, thank you, Antti, very interesting presentation. How has the data been utilized, especially when it comes to making informed decisions? For example, financial data or number of beds? You both can answer. You want?
Sure, I can start. Well, we are, as I said, we are a centralized unit. What we do, we hope it is utilized well. What my team focuses on is providing the data once it has been recognized by the end users what they need, and then we work to procure the data that they need and help them to form it into visual analytics. And our unit also does or helps in change management, and that is something that Pia and her unit focuses on.
Thanks. And for the rest of the presentations as well, if you have a question, you can write it down to the message board already during the presentation, and we will get to those at the end of the presentation. But if you have ideas and new questions right now, you can also raise your hand and tell us. There's a question on for Pia. Presentation was very insightful with regard to the PU assessments and reports. Has this increased the patient's experience of care?
Thank you for the question. No, not at the moment, but this is very interesting. Yeah.
Yeah, I guess we still need more time and data to assess that. Then a question on, are you using data to, I guess, trigger preventive interventions or actions for personnel or even patients? For example, prevent unnecessary emergency department admissions or similar. Pia or Antti, do you want to comment on that?
Yeah, if I understand it correctly, this is something where we run into the data protection legislation in Finland and in EU. I guess Emil can also elaborate on this if I'm unclear on this, but the data lake where this data is and where we use it, it's cleared for knowledge management and organizational level analytics and reports. There's next question, a question about the registered medical device, and if we start using data for that, then it very quickly goes into the territory of registered medical devices, and we use these reports to recognize possibly wards or units where there might be need for more training, and as such, it is not directly related to single or individual patients.
Right. All right. Thank you very much, Pia and Antti. And now we will move on with our program. We will continue with the theme on visual reporting. But next up, we've got a presentation from Karolinska University Hospital from Sweden. And the presenter is Fredrik Hullerstedt, who is a business developer with focus on planning and data visualization. I'll hand it over to you, Fredrik.
Thank you, Emil. Can you hear me all right? And can you see my screen?
Yes.
Perfect. I'll say the same thing that Antti did, that this is my first time presenting on this in English, so I might make up a word or two. And also, Antti, I'm pretty sure Santa lives in Sweden, so we can settle that right away. Because I'm from Karolinska, and we are situated in Sweden's capital, Stockholm, which for international audience would place us about the same latitude as the Hudson Bay. Still a bit south of Finland, though, but in the northern part of Europe. So we are one of Sweden's largest hospitals, with about 1.4 million outpatient visits every year, and about 86,000 inpatient episodes. We are one of, I think, 5 major hospitals here in Stockholm, and we are divided over 2 sites. Just across the road from us, we have the Karolinska Institute. So we are the hospital part of the Karolinska organization. So among other things, they hand out the Nobel Prize in medicine and physiology. So we are the hospital wing of that organization. Our focus is on providing the highly specialized care here in Stockholm, and to support all the other hospitals in doing the major difficult surgeries. I was actually supposed to be joined by our Chief Medical Information Officer, Patrick, today, but he sadly will not be able to join us. So I will do this presentation on my own instead. I added in here our mission and vision. So we are trying to cure and relieve what no one can cure and relieve today, focusing on taking our the medical science forward together with the university, Karolinska Institute, on the other side of the road. So I was thinking of structuring this presentation. I will talk about a bit what I do and what my team do, and then we will jump straight into some of our visualizations. And I will actually try to show them to you live. I have backup pictures of them if necessary, but we will go for a live demo and hope it will work out okay. So I'm from Karolinska's production unit, which is a part of the staff for the Chief Operating Officer. We are a fairly small unit of about 5 full-time employees, but we do have a wide range of responsibilities. Among other things, handling the planning for the hospital, and also the data that comes out of the planning, and also building the visualizations of this data and doing the follow-up during the year, and actually how our results are compared to our plan. We also do a lot of work with integrating new systems into our data lake. When you have a clinical system that needs to be integrated, usually we are the ones who are writing the specifications and working closely with our IT department to structure the information in a way that we can actually use it. We are also the super users for our business intelligence tool, which is Tableau. So we handle a lot of the questions that come up surrounding Tableau, and we do education for our super users that are out in our organization. Who will we do provide the centralized follow-up reports, and they are working on the more local. We have about, I think, 25 super users in Tableau all around the hospital who also cooperate with a lot of other people outside in the organization. Didn't mention that, but we're about 16,000 in total. And finally, the last job of my unit is also to provide a lot of ad hoc data analysis and providing data when it's asked for. If someone asked about our queue situation or how many patients we treated and anything like that, since we're a public hospital, we will provide that information. And I can also say that we're a publicly funded hospital as well. So our core principles for data visualization. We want to try to keep our visualizations simple, because we know that they are going to be seen by a lot of people. They're going to be seen very quickly, and they need to be able to quickly and easily identify the core message. We want to keep our visualizations transparent, in that we don't want to add several layers of calculations or like things that makes it hard to understand what is actually happening, because we have been our path to becoming more data driven has been one that has been very much focused on combating the feeling that you as a clinician, you don't recognize your own data. Therefore, it's been very, very important that you provide a single source of truth that is very transparent for the individual clinician to know that, okay, this is my data, this is my plan, this is my patients. I can see how this flows from the clinical systems into the data lake to our visualizations. Also, we want to keep it uniform. And with that, I mean that we want to make sure that everyone looks at the same data, and preferably in the same visualization. So I'll come to that when I go into the visualization I'm going to show you. I will go through 3 of our visualizations today with you. One that is our major production overview, which is a simple visualization with a high data throughput that is used by the entire organization. We'll look at one that is tailor-made for our emergency ward or emergency room to understand the situation there. And also 1 or 2 that we use for ad hoc data visualizations during our like when we run into a problem or a project where we quickly need to take out some data, and how we create a visualization for that. So without further ado, I think we will try to jump into the live demo, and if everything collapses now, we will have a bit of a problem, but I think we're all right. Okay, so this is actually our main report for following up on how the hospital is actually doing. It's in Swedish, which might make it hard for some of you, but hopefully it should not be that difficult to understand. If I say that this is our inpatient visits, you will quite probably see that all the red bars here indicate that we have not been doing so okay, and I think my visualizations need to reload because I was smart enough to open them in advance. So while they do that, perfect, I will say something. As you can see, we are working on a quite simple layout where we try to keep all our visualizations with a gray background. That would be the plan, and the bars in front would be the outcome. So in the case where you have where you want to achieve a higher level than the plan, you will see that they are colored red or green. And if you are not expected to actually overperform your plan, you are supposed to be on your plan, then you will see something like a blue line only. So this report is updated weekly. Each of the bars you see is 1 week of the year. So we had a good first week, a few good weeks around the summer. And then I think this is one of our vacation weeks where we actually did very well. Apart from that, our inpatient care, the number of inpatient care episodes has been quite low this year, while the outpatient care has been a lot better. Here you see we are above the plan. And the way you're supposed to use this report is actually, like what we're looking at right now, is the entire hospital. This is a report that gets sent to our CEO once a week because we update this weekly every Tuesday. But this report is built so that you, regardless of where in the organization you are, you can filter it to arrive at your specific department or organizational unit. So if I'm a part of, let's see, our children's hospital, which would be Tema Barn, I can just easily filter it and it will look the exact same way, but it will only show the children's hospital. This is in order so that you can use the same report regardless of where in the organization you are. Even if you're head of a section, you will use the same report as the CEO does. And this means that when you are having meetings between different levels of the organization, you will come around or you will use the same report and you will feel at home because you will know what it shows. It also has an opportunity. This is the overview, which is to give you a quick summary of where you're at. You can get some more information about what you're seeing by hovering and getting some Swedish information. But if you want to dive deeper, you can do that in each of these swim lanes, which we have. I will go through all of the swim lanes later, but you can dig deeper into each of the swim lanes by pressing one of the two icons here. I won't really do that because they will take some time to load, and I have preloaded it here. So as you can see, this is the same report. A good week in the beginning, a few good weeks around the summer, and one vacation week. But here you have a lot of additional ways of breaking down the data. If you, for instance, want to look on emergency or planned care, if you want to look at based on where the patient is from, if it's from Stockholm, if it's from the rest of Sweden or the rest of the world. And also what time scale you want to use, if you want to have the breakdown weekly or monthly. And we also try to use this report in our planning for the coming years. So you can actually use it and you can change what you're seeing in the report. So right now we're looking at our outcomes this year and our plan this year. But for instance, if I would like to look at, for instance, our for the planning next year, we can actually take a look and see, okay, so this is this year's outcome versus next year's plan. So we can easily see here that, okay, here in September after the summer, we would need to work a bit harder next year. So as I said, we try to keep it uniform across as many parts of the hospital and organizational streams as possible. So if you can use the same report for planning as you do for follow-up, that is something we value greatly. So this report contains, as I said, several swim lanes. So you have, for instance, inpatient care, DRG points. For those who are familiar with the diagnosed related group system, we are actually receiving our funding based on how many DRG points we produce. So it's very, very important for us to follow that metric as well. You can see the mean time of a inpatient care stay. For right now, it's 4.1 days, and you can see that it's been fluctuating a bit across the year, slightly lower in the summer. And here we have the same again with number of care episodes and DRG points, but for the outpatient care instead. And then you can move down to see our emergency room. How many people have been staying more than 4 hours? And how long have you been staying after you were officially decided that you're supposed to be admitted to, or you're done in the emergency room? And we can see that we have some potential for improvement here. We also use this report in a way that, because we have an organization where you have two different parts. You have one part of the organization that owns the patient and the entire patient journey through the hospital. And you have the other side of the organization that actually provides all the resources. So when you look at it from the other perspective, from the perspective of an organization providing resources, for instance, if you are running a hospital ward and you are providing beds for the patients, you can use the same report with the same filters and the same layout where you have your plan and your outcomes. So this would be the number of days that people have been staying in the inpatient care. We're seeing that we're a bit low on that as well. And here are the number of placements in the inpatient care. So we've been having 127,000 different places, which means that you have an average of 1.5 placements per inpatient stay care, approximately. Okay. And second break, if you have any questions, Emil, that would be a great time right now.
Yeah, I don't see any at the moment.
Okay,
but,
perfect.
All right.
Then we'll move on because now the report is back. Here we can also see the number of admitted patients. So we had an average about 1,000 admitted patients this year, and our average amount of open beds. So here you have both the plan and the average outcome. So we had a plan for about 1,110 and an outcome of 1,033. Going down further, we will see outpatient care. So this is actually our line or our queue for new patients that is visualized in the same visualization. So here you can see that we're keeping the number of patients waiting quite steady. And we are also counting the number of patients that have been waiting more than 30 days. Is the red part, and together with the blue part, which are patients that have not been waiting too long, makes up our entire queue. So we are working on cutting that down at the moment. So this is actually like one of the reports that we have put the most time in on. It has a completely custom-made underlying data source that is specifically made for this report to ensure that it loads quickly because it pulls in data from all our different data sources. So trying to, for those of you who has been working with Tableau, trying to blend the data source straight away would give a report that was incredibly slow. So we actually spent the time and built a custom data source for this. So this, because this is one of the most central reports we have on the hospital. So saying that, I think we can move from the very, very general to the quite specific. If this report has been an outcome of the wishes of upper management for how we are supposed to follow up what happens in the hospital, the next report that we're going to look at is our crowding tool for the emergency room. Okay. This is something that has come into existence in a very, very close cooperation with the clinical staff in the emergency room in Huddinge, which is one of our sites. It's actually the digitization of an existing tool, and it is used to measure the level of crowding in the emergency room. So what you can see here, hopefully, is or that you can hopefully also interpret, is the situation in the emergency room, which for now is quite not bad, but not good either, as they said in Chernobyl. Not good, not terrible. And this is based on a system that was devised by our clinical staff, where you can you have 5 different measures that all give points that you can summarize and realize what level you're on. So you have points for number of people in the emergency room, points for number of people who are to be admitted into the inpatient care, points for the number of highly prioritized patients in the groups 1s and 2s, which are like emergency patients. And then you have points for number of patients who have not been seen by a doctor, and points for number of patients that have been waiting more than 8 hours, which happily right now is 0. Adding these together, you get a score, and that score runs from, I think, 0 to 100. And once you pass out, once we're in the blue, we're at normal operations. But once we leave the blue area and enter the orange and deep red ones, there is a process that will be triggered. This is a way, as I said again, I said before, to create a report that the entire hospital can come together around. And it also contains, if you would look at these colored buttons here, that their color corresponds to the level we're at right now. So if we, for instance, would go to the level 1, we could actually see what are the expected processes and routines that are supposed to be carried out by different functions in the hospital and in the emergency room. And this is in order to handle the situation in the emergency room based on the experience of the clinical staff. So this is all this is all just free text that has been written in order to facilitate the flows from the emergency room into the to the hospital and make sure that patients are sent home when it's necessary, or sent home when they are done, I would rather say. And as you progress further and further in the levels, in the levels of crowding, you will see the actions and the processes that are available to the staff automatically becomes more and more. The tools become stronger. So when you are at a really high level, you can pull in resources from the hospital. So this is a way for to manage expectations over the hospital, because everyone can go into this tool and see, okay, where we're at now. What would that entail for the operations of the hospitals? If we would get more patients, or if something would happen, what can I expect would happen to me? Will someone call me and tell me to do something? What is going to happen? And also, how could I help the emergency room right now if, like, there are maybe a lot of patients that has not yet been visited by a doctor. Maybe there's not so much wards can do about that, but if you have a large number of patients in the emergency room waiting to have an inpatient bed, then we know that, and the wards can actually help the emergency room. So we'll see. We have one more of these. Yeah, exactly. These are the instructions again. So now we looked at two visualizations that are that we've been working on for a long time, that has had a very clear path to bring them into existence with a very clear structure. But what we're going to look at next is how we work when we have a more ad hoc process, where we actually just run straight head first into an issue that we need to work with. So this, let's see if this reloads. Yeah, it does. Any question? No. Oh, this one is quick. Okay. So what we're seeing here is a report detailing how many temporary staff we hire. So this is something that we had to start working with in March. We received from the political leadership in Stockholm an instruction that we're supposed to have fewer hired staff, and during the year we have been decreasing our dependency on externally hired staff. And this report is not as well built from a data management perspective as the other two that we have been looking on, because it is actually a very, very handmade systems integration between our system that handles all our when we send requests for hired staff. That system, we actually just extracted all the information from that in an Excel file and integrated that with our existing data sources in Tableau by an table in another Excel file that just joined the two organizational trees together, so we could actually use this data. Because when we came into this year in January and February, we didn't actually know how many people we actually, how many hours per day we actually had hired temporary staff. We only knew like 3 months down the road, because we were basing that on the invoices that we received. So this was built in the middle of the night. I'm actually a bit ashamed to admit, but in order to facilitate us actually knowing on a day-by-day basis how is the situation evolving, how can we follow what each individual department is doing. And again, this has the same filters and same structure as the first report we were looking at. So regardless of where I am in the organization, I can use this. This is the entire hospital. And I can filter this. So again, maybe let's look at our children's hospital. We can see here that they follow the trend quite well. And see, let's get back. Exactly. And we also have, this is the way generally we structure these reports, like with one overarching view that gives you a visualization of the data, and then down below a table where you can go in and see for each unit in this case. You can actually change the level of detail here. So you can, yeah, they have the same number of sections as they do. Perfect, there we got some more. So this is actually basically the same data as you can see visualized up here, only much more detailed and in a broken down a further level. So you have the amount of time that one of our wards wanted to hire a person for, the amount they actually got, and how much, what percentage that is, which corresponds to this. So the yellow path here is how much we actually asked for, and wanted. The blue is how much we got. And this has been used all throughout the year for us to follow how much higher staff we have. And it contains some quite interesting features. Since the organizational tree of our other system that contains the data does not match the one we have in our database. But as I said, we have a custom integration in an Excel file, and this report actually contains a little square here that if someone adds a new department in the other system that is not mapped to our own data structure in our data lake, this will turn light blue, and we will instantly know that this has happened, so we can go in and actually manually fix this. And this structure, trying to have a graph and a table for details, actually comes true in a lot of our reports. So this is one we use for higher staff. This is one we use for planning for how many open beds we are supposed to have during Christmas. So the blue bars you can see here is our prognosis for how many beds the entire hospital is going to have. The yellow and gray lines are previous years for number of admitted patients and number of open beds. Yep, so perfect. And as you see, you have a graph on top and then a table at the bottom that you can use as a department head to actually go in and look at your individual department. Okay, what are the actual numbers for me on Christmas Eve? What are the actual numbers for me this year and last year? And actually use this to get a very high degree of granularity at the same time as you can get an overview of the entire hospital. Yeah, so let's see. I'll keep that one up. So I was thinking of winding down and maybe going to Q&A, but before doing that, I was thinking of maybe saying some final words that are here in my notes. So as we said, we want to keep our visualizations as simple as possible, and I think this is a good show of that. You keep the number of variables low. You keep focus on the information that you actually want to show. You want to keep it as transparent as possible. As a department head, you can actually go and see, okay, we had 7 patients admitted last year. And we want to keep it uniform. You can use this to look at our entire hospital all the way down to an individual ward. And the purpose of this is, of course, to keep on going on the journey we're on, where we become more and more data-driven, and where we try to handle the very diverse data landscape that Karolinska used to have, where there were multiple sources of truth. When you were supposed to cooperate, you more often ended in a discussion about who has the better data and whose data is the correct. As we do now, the central report is our single source of truth, and if you think that it's wrong, then you can come and talk to the central unit, and we'll have of course, if it is wrong, we will change it, or we will have a discussion why you have chosen to show something in one way and not the other way. So to conclude, we want to try to have our data visualizations as the gathering point of the entire hospital, where the discussions about what we do as a hospital can start and can flourish, and not get stuck in actually getting to know the truth before you can actually do something. So, Emil, may I hand the proverbial microphone back to you?
Thank you, Fredrik. Thanks for the great presentation. We have some questions, and there's a hand up at the moment from Sini Tenhovuori. Go ahead, Sini.
Okay, hi everyone. This is Sini Tenhovuori. I'm working as with the human resources knowledge management at Pirha. So it's nice to hear that you also report to hired staff, and it's also quite manual with us. We have this kind of visualization where we also put the hired staff into the map, since we are a large area. So, but nice to see those visualizations that you made, and we have a little bit different, but also the same thing. We're trying to put it down.
Yeah, hopefully we won't be needing them, since we are trying to minimize the amount of hired staff we have. So, but we'll see what happens.
Yeah.
All right.
Same with
Thanks.
me.
Then there's a question about how real-time information is on the report. You mentioned that one of the reports was updated weekly, but were there differences in the frequency on the reports that you showed us?
Yes, there are. Very good question. Thank you. We have a report like the refresh frequency on the reports are very much attuned to what is actually needed. We have monthly reports for like salaries and things that are only really relevant once a month, down to all the way to, I think it's we actually have some reports that are connected live to our data sources that actually have the latest data from our clinical systems that's available, and I think that is up to a 5-minute delay to actually have that processed in the data lake. So it goes from all the way from yearly or monthly to every 5 minutes.
Thank you. You actually kind of answered a few more questions with your reply. There's a question on who captures the data or collects the data, but as you described, many of it comes automatically from the system, right?
Yeah, we that is also one of our cornerstones. Actually, trying to make our reports as automated as possible, working with not having to go into the report every month and actually change something just to make update the dates or something, but actually creating a report that is automatically updated. That is, I will say that the report on hired staff is an outlier, since it actually requires us to go into the report and actually update it. But that is also because it's a working tool that we create quickly, and therefore there is no structured integration to the system that contains the data. So then it was just like to get your hands dirty and just do it, because we needed to know this, we need to know it now. Then I ended up having to sit every morning like downloading an Excel file and pressing some buttons.
Right. Yeah. And in our organization, it's the same, that some reports are automatic and others you need to have some manual input or kind of crowdsourcing of the data.
Yeah.
Did you mention that you have the data lake or kind of a data warehouse where you get the data from different sources under one roof and connect Tableau to that?
Yes, exactly. We have a data storage called Karda, which is Karolinska's datalager, which is a funny little name for it. I think we every night I think we put in something like 300 million rows of information into it, and there is a lot of information flowing into it. Not all of it is, of course, or not of course, but not all of it is visualized in Tableau, because of course you have very sensitive like patient information that you for obvious reason cannot put in a public Tableau report. And we have not gotten as far as you have, because I think one of the reasons I'm here is actually that someone from my hospital went to you and saw your really cool dashboards in your wards and said like, why don't we have that? And then they told us, can you fix this? And we're like, we're working on it. But yeah, I think we have about 300 systems integrated into our data storage, and not all of them are like they're all at different levels. Some of them just push the data into the data warehouse, and I'm pretty sure no one actually looks at it. Then you have the data that is amalgamated and cleaned to a certain degree to be used, for instance, in background processes. And then you have the data that goes all the way to Tableau, where someone has actually gone into to the data lake and built a view that is the actual data source that we then publish to our Tableau server.
Yeah, in some, like you said, in some cases the data is clean. There's a question on quality assurance measures. What kind of measures are you taking to ensure the correctness of the information?
Mm-hmm.
Are there more than what you just described?
Well, a lot of the information that we deal with come directly or is automatically generated from our journal system. I'm not sure if the journal system is the English word, but
EHRs, electronic health records. Yeah.
Exactly. There you go. And that data is.
Lähdetään. Kuka siellä nyt tulee?
Go ahead.
Yeah. Okay. So that data would be the data we actually that we use in our. So we don't really do a manual check on that, but oftentimes, I mean, we had a problem a few weeks back with one of words changing names, and that broke down some of the mapping tables. And then it was actually sometimes we know that what we're supposed to look out for, and then we have specific Tableau reports set up for that. So they are generally, maybe if we know that two things are supposed to balance, then you can look into that, and if they don't balance, then you get a warning. But it's also sometimes the actual end user that comes to us and says that, hey, I am not gonna treat 10,000 patients today. You better look at this report. And we're okay, sure, yeah, sure, that's right.
Right. One more quick question, but not an easy to answer, I guess. If you can make one wish on improving the visualization or functionality to be more outcomes driven, what would that be?
Oh, more outcomes driven. That is a very interesting question. Well, to begin with, I would have to say that we need to find what outcomes we actually want to measure. And my one wish would be that the hospital would actually be clear and have a good understanding of this. These are the outcomes we want to measure, and then have a focused vision for actually getting there. And because there is so much data, we can measure outcomes, so we can do that, but we need to focus and we need to find measures that are stable over time and that we can all get behind.
Right.
So maybe less about the visualization, more about the organization.
Right. Hey, thank you very much, Fredrik. This was very interesting.
Thank you.
We'll move on in the program to our last but not least presentation. We will hear about visual reporting in the Northwell Health from the United States. And Northwell is the largest health system in New York with over 85,000 employees across 23 hospitals dedicated to caring for over 2 million patients annually. We have three presenters. First, Douglas Barnaby, Director of Evidence-Based Clinical Practice. Doug focuses on ensuring the organization has the tools to provide high-quality evidence-based healthcare. And then we have Shagayek Norozadeh, Senior Director of Process Improvement. Sherry is a systems scientist leading and executing major transformational initiatives to improve the quality of patient care and achieve strategic organizational goals. In addition, Sherry teaches continuous improvement courses at Northwell's Center for Learning and Innovation. And the third presenter is Juan Rada, advisor in business intelligence. Juan is a data analytics leader with extensive experience in building and mentoring analytic teams to develop innovative business solutions. And Juan is also leading and fostering a data-driven and data-informed culture at Northwell Health. So all of you, please welcome. Go ahead.
Thank you so much, Emil. It's really an honor to join this group and describe some of the work we're doing. Two points just to touch on before we get going. One was called away on an emergency. He may be back in time, but we're well prepared to fill in the gap there. Two, despite having presented this material in English several times, I may also make up some words. Since we are from New York, we're very loose with the English language. So I will not slip into Finnish or Swedish, but feel free to post any questions as we go along in the chat. Let me just pull up some slides. Thank you, Sherry. All right, so very good. As Emil said, we're from Northwell Health, the largest employer in New York State and a health system of 23 hospitals. What we're going to do is we're going to pivot a little bit today. We're pretty facile with Tableau and dashboards, but a lot of what our team does is we try to understand problems more clearly. And to do that, we deal a great deal with the messy side of qualitative data. We do a fair amount of one-on-one interviews and focus groups and field observations of processes, which don't readily translate into a Tableau report or a Power BI report or some statistical analysis. But as it was mentioned at the beginning of the talk, we have to get the information across in a way that's digestible by our leaders and managers. And visualization is one of the key tools that we tap into to accomplish this. So what we're going to focus on is just one example of what our team is focusing on right now, which is improving inpatient diabetes management in our health system. We have some clear ideas about outcomes, but as we tackle this problem, how to get to improved outcomes is always a challenge, especially when you're dealing with so many moving parts. So as we walk through this sample, it's just this is one project. It's live. We're dealing with it right now, so it's going to be a little messier than perhaps a well-polished Tableau dashboard. But we'll finish off, I think, with a couple of well-polished Tableau dashboards just to prove that we can do it. So again, 23 hospitals across the tri-state area. We're closer to 850 outpatient facilities now. We've got over 79,000 employees. We take care of 2 million people a year. So a very large, unwieldy health system, where, as you can imagine, trying to promote consistent adoption and uniform delivery of care is a challenge. So what our group actually at Northwell is dedicated to, but Sherry and I are a part of, is the Department of Clinical Transformation and Improvement, which is recently expanded 15 to 20 people, spread across improvement scientists and implementation experts, systems engineers, data scientists, project managers, program managers, and really it forms the infrastructure to do a lot of this important work. I'll say that, right now, our focus is on inpatient hyperglycemia, and just to go back to what Frederick said, clarity on outcomes, that's one of our challenges as well. And what we typically do is we partner with either local sites or system leadership to identify problems that we want to address. So for this example, we're going to focus on inpatient rates of hyperglycemia, which not only are tied to important clinical outcomes, but on the financial side, our Center for Medicare Services is now suggesting this would be one of our national quality measures, which will be tied to reimbursement and quality measures. So this has pushed a number of buttons at the system level, both at the local facility sites, the department sites, and will be the example that we kind of walk through here. This is should be familiar to most people. This is a Tableau dashboard. This demonstrates that we're consistently not where we want to be. So where we want to be is have rates of hyperglycemia well below 7 or 8%. At this one facility right now, we're in the double digits, and that was our mandate from leadership to say we want to do better at this process. So this is an example of one facility, which is Huntington Hospital. Their goal on their dashboard, this is where we get a lot of our clarity from, is that we want to improve glycemic control in hospital patients. And to do this, and I'm not sure how far this has reached around the globe, but there's this concept of a learning health system. where we use our readily available data. We convene multidisciplinary teams that include both clinicians, managers, and leaders, as well as technical experts in industrial engineering and data science. Bring them all to the table, and we collaboratively design and co-develop solutions that we test and pilot. By no means is this a panacea to some of the dysfunctional communications and politics across healthcare, but it's a model that we've adopted and had a great deal of success in that we are bringing everybody to the table to co-develop solutions. There's not the data team building something, handing it off to the clinical team. 2 months later, the clinical team saying, well, that's not really what we want to measure. We want to measure this. And then it gets revised and handed over to leadership, and leadership says, well, the landscape has changed a little bit. We're looking to measure more financial outcomes. We put everybody at the table together so we can get clarity and make sure that everybody's aligned to the same goal. So I won't go too much deeper into learning health systems other than to say that it's this kind of iterative process where we start at the bottom. Our problem of interest in this example is hyperglycemia, but we start by capturing data on what we're currently doing. So current state is where we start all of our projects. This requires, close relationships with data analysts and informaticists. From that data, we try to turn that data, which includes not only the quantitative, but the qualitative as well. And we try and generate knowledge from this data using our industrial engineers, implementation scientists. I left off our medical anthropologist on this, but we do have an anthropologist that occasionally does field observations and does a lot more qualitative work. And then we try to turn that data, into knowledge, which can help us develop solutions. So for this project, for this talk, we're really going to be focusing on these 3 steps in the process, which is collecting data, generating, visual models of what we think is happening on the wards, and then analyzing those data in order to come up with solutions to pilot. So at this point, I'm going to hand over the talk to Sherry, who's going to tell us a little bit more about how she uses the existing visual tools to understand problem and context.
Yeah. So good morning, good afternoon, everyone. Good evening. I don't know, depending where you are. And thank you for having us here today with you. So as Doug mentioned, we actually we will show you some dashboards along the way, but what we want to basically focus on a little bit is how we work all together to come up with what should go in the dashboard, what is meaningful, and how we are going to measure what do we want to measure and how is it going to impact our outcome. So Doug, if you please go to the next slide. So one of the tools that we use to get that understanding among different team members and stakeholders, as Doug mentioned, from like the leadership to frontline staff who are taking care of patients, is swim lane diagrams. I don't know if you guys are familiar with it. Maybe this is not a process improvement group. More of you guys are working with quantitative data and dashboards, but this is a way to learn the process knowledge, to capture that process knowledge and understand what is happening. We have all policies, procedures, what should happen, and we all know that in the day-to-day operations, like we all do, the clinicians also have their own workaround, and they have to come up with ways to deal with hard volume and the exceptions that are happening in the patient flow. Is there any questions? Okay, so I'll continue. Great. So for us to put this diagram, we don't want to test your eyesight. I mean, if you can read it, that's amazing. But what we want you to see is that managing glycemic control for the patients coming through the ED to go through the inpatient and getting discharged is a very complicated project, or not project, process. As you guys can see, there are a lot of roles involved in it. So each lane here that you can see, there on the left side, you can see that there are different lanes, and those are basically different roles. So we have 9 different roles involved from the beginning to end, involving from the ED side, the doctor, the nurse, pharmacist, and then if they get you know, admitted, then we have the whole nurse, and then we have hospitalist, nurse practitioner, or physician assistant. And we have on the floor, we have also nurses and pharmacists and nutritionists, and obviously labs and ancillary services. So all of these roles are going to touch this process at that point. And we sit together and develop these kind of diagrams just for everybody to see how complicated the work is. So why we need to sit together and work together to, make it more easier. And what do I mean by complication? Doug, if you just click once. So just think about a doctor on work on their day-to-day rounds and visiting patients. What happens? They check and treat glucose. They determine the glucose level. Then they have to, those diamonds, blue diamonds, or point of decisions. And then they need to make a decision. Is it in control? Not. If it is not, then review other steps like reviewing the fluids and steroids and so on and so forth. As you can see, on day-to-day basis, a physician needs to go through all of these steps and make all of these decisions for each and every patient. And think about, all the patients that are in the ward and all the decisions that they need to make, and how much support really we give them to make those decisions smoothly, because we know that we are all humans. We have good days, bad days, or emergencies, personal emergencies, and this and that. How can we ask people? I mean, I know that they're heroes. We know that they're heroes, but they really don't have those superpowers to make all of these decisions and go through all of these smoothly without our help. So Doug, if you go back, please, to the, just one more click. Thank you. So, and then looking at that, just for one role. And now let's look at all the information that needs to flow among different roles. If you click one more time, there are 20 points, just forward. Yep. There are these arrows, red arrows, that are actually showing you where the information needs to be passed to the next role. This is 21 time from patient is in to patient leaves. That's a lot of room for error, because this process is heavily dependent on people and the interaction between people and different roles to make sure that we are going to make the right decisions. And those blue diamonds are actually the decision points that are, if I'm not wrong, about 14 of them that needs to be made. So each and every of these are going to be making our process a little bit more fragile, prone to errors. And our work is to figure out, do people in these roles have the right tools and support and help to make those decisions so that we will have less errors. If we can go to the next. So now, in that complicated process, let's look at the value. What is making that value stream for us? So that is going to be the purple steps in the middle, highlighted in the red box. As you can see, after the hospital admission, we have the initial evaluation, and I can't even read it myself. And then admitting orders, daily evaluation, medication adjustment, medication administration, then patient education, and then preparation for discharge. When they get discharged, and of course, we need to do the follow-up visits and the support for patient education, and if they need any equipments or anything for their medications and all of that. So, and we are hoping that that acute illness visit doesn't happen and everything will be managed with the follow-up visits. So this is basically the value that we want to drive. And so to be able to drive that value, we need to know more about the information flow, or who are the people who are taking the data, making it information, pass it to the next role. And that is going to be the layer on top. As you can see, those colorful circles are different roles that are involved. And you can see for one step, we have different roles involved in evaluation, making decision, passing the information, and all of that. And as the saying is, to the fastest way to starve a horse is to assign multiple people to feed it. So when we don't have those clear responsibilities for each of these steps, what will happen is that sometimes we don't know, did the information pass to the next group of people that need to work on the patient and make sure that this process is smooth, yes or no. So those are all the things that are kind of in a level of mystery for us. So on this value stream map, on the blue turquoise color, I don't know, I'll call it turquoise. I don't know, maybe you guys won't. We added some layer of data, the compliance for each of the steps, how many times this information, this value is going to be passed to the next level. And I just noticed that friends in Finland, they mentioned that their MedRec in the first 8 to 12 hours, I think, is done by the compliance rate of something around 80, 90 rate. And I was just, wow, this is wonderful, because for us, we were at like around 30%. So not where, but clearly not where we want it to be. And we all can agree how important it is to do the initial MedRec so that we have a smooth process. On top of that, as Doug mentioned, we had those focus groups. We sat with people, stakeholders who are taking care of patients day-to-day basis, to figure out what they do, how they go about the process, and what challenges they have, what is on their wish list, and all of that. So that is going to be the next level for the evaluation. We went through those challenges that people had, and one of the themes that came up was exactly about how they need to prioritize. What are the priorities? What are the competing priorities? And the fact that the process is heavily dependent on the physicians, and to some levels on nurses, who are the busiest people in the hospital. And we are asking them to just make sure everything is smooth as well from the operations. That was the challenge that they had. And now before going to the future state and for the information flow, you can see that the graph is slightly looking better and there are less hands on, but we're not there yet. We haven't, as Doug mentioned, we're working on the project as we're speaking about it. But now next, Doug is going to tell you a little bit about the solution development and how they're working and what's there.
Yeah,
Thank you.
Thank you, Sherry. And just to recap, Sherry's work, and we had 2 slides on it, but it's far more involved and takes probably the most effort is understanding the current system. As you can see, it's a very complex system, multiple agents, multiple handoffs, lots of data swirling around. And we do have, messy qualitative data, up alongside quantitative data. So, the way we approach this is that, we try to translate this into a much more understandable visual model. And, despite the fact that we breezed through them, the visual models Sherry just presented are far more interpretable and far more actionable than the 50 to 75 pages of focus group interviews and tabular data. So, the goal really is to turn data into knowledge in a way that empowers us to craft solutions. Again, not independently, but with our stakeholders, our leaders, our managers, and our clinicians. So, from that purple line on that previous value stream map, there are these steps, and the way we approach improvement is we try to figure out, so what are the systems that we can build to support our providers and the people providing direct care to patients with the right systems to deliver care, not only effectively and efficiently, but in a way that reduces their cognitive load, their workload, and reduces burnout and stress. So what we're focusing on right now is one solution that we're in the process of developing, which is a pharmacist-led inpatient glycemic management service. One of the learnings that came out of our earlier work was that, our hospitalists, our physicians taking care of patients in the hospitals, carry between 20 and 30 patients on their service, each of whom has 4, 5, 6 active issues. And oftentimes, glycemic management can be 3 or 4 on that list as you're dealing with respiratory failure, kidney disease, infectious diseases. And quite frankly, they're overloaded with a dysfunctional EHR and multiple responsibilities. So out of that, we performed some basic implementation science and said we can task shift some of these responsibilities over to a dedicated pharmacy team, which is the solution we're currently testing and developing right now. So again, there are numerous models of caring for patients with with diabetes on the inpatient service. Based on our available resources and our existing barriers, we focused on establishing this inpatient glycemic management service led by a clinical pharmacist with special expertise in diabetes care. And to make this sale even more clear to senior leadership, is we took that multiple swim lane, multiple agent diagram, and we said, really, what are the core factors that we need to focus on? And we need to present those core factors. Going back to what Frederick said, give me some clarity around the outcomes, not only the outcomes we're trying to achieve, which is reduced rates of hyperglycemia, but show me the path to getting to that improved outcome. And so from that very complex diagram Sherry presented, we are down to 6 boxes, which are in collaboration with our clinical leaders, our experts. We said, if we can just get these 6 steps consistently correct, we can anticipate improved rates of hyperglycemia. And so to make this even clearer for leaders as we look to get support for this team, these are the 2 steps that we consistently kind of underperform on. Sherry mentioned 18% on the MedRec. We're actually closer to 90% now on this pilot unit. So the 2 steps that really jumped out, once you match up this co-development of solutions, this collaborative work, are around our initiating and adjusting long-acting insulin. So this is easy now. We've got a very complex process. We can put this 1-page diagram in front of leadership and say we need support to address these 2 steps, and this is the system we hope to build. So to jump into the data, Juan, good to see you back. We're going to let Juan kind of walk through what he's done on the data side, which may be more familiar to you all.
All right, thank you, Doug. So this has been a very interesting project, as many of you that have worked in many data visualization projects. One of the challenges here is like, where do you start, right? It'd be nice if they'll come to you with all the specs, with all, we want X, Y, and Z, and this is what we want in our dashboards and things of that nature. But part of this learning community, it was a messy start, right? It has so many points. There was a need to understand multiple data points and understand how they related to each other. And as we go from, having dashboards that showing you like, regular KPI or a key performance indicator, we're starting to see our work is more like this, right? You have a messy start where you are exploring the data, where not necessarily it is a dashboard that is going to be consumed for, for multiple people, but at the beginning is just to understand the data. So here what we're showing to you is just different things that we're looking at the data. We wanted to understand how, for example, the glucose levels of a patient fluctuated and how that matched with all those processes that they were explained before, and how compliant we were in all of them and how we're able to measure them. And if we make an intervention, do we have a way to measure that intervention and things of that nature? So working with the team, we look at different things. We're looking at, for example, we'll take one patient, we understand where they were. We're looking at all the glucose levels. We're looking at how much insulin was being administered, how much that insulin was being changed based on the fluctuations of, the sugar levels of the patient. So this is how we started with a message star in our data visualization. But I think it was very important as we were, in this partnership with this team on the delivery, onto finding those insights, into finding what exactly they wanted to measure over time as they were going through this process. So next slide. So one of the things that we wanted to start with is being part of a large health system. We have multiple hospitals, and then we do see a variation between all our facilities. And what we always call here in North Valley is this an opportunity grid that really allows us to identify of all of the facilities that we have, which of them are meeting the threshold and which are not. So it does help us to focus as well on which to target. So literally just become one insight, right? This dashboard is really one insight to help us just pinpoint, who will be a great candidate. So on this one, we're looking at, number of patients that had a specific threshold, and also on the x-axis, we have the number of patients. And this gives us understand, how much we had a problem with, and also to understand, how many patients we'll be able to reach if we were to make an intervention in the hospital. So this grid, it helped us to do that. So we wanted to, so first step, as when we started part of the discovery, is to really understand what was happening across all the health system and identify those hospitals for opportunity. Next slide, please. And then one of the things that, as we went through these processes, that we wanted to have a centralized location for the data, right? We don't want to have our multiple places for the data to live. We wanted to connect, the outcome measures, what they wanted, what is their reason, like the why, what they're trying to measure. But also we wanted to incorporate process measures, all of those interventions and how we're able to, measure them and see how they relay between once you make a change in your process, will it also affect your measures. And part also, every time that we're trying to do improvement of care and things of that nature, it comes with a cost, right? The cost of the time, the technology, nothing is free. So part also of our work is, are we able to identify possible return of investments? We do have a specific measure that we're trying to, an outcome measure we're trying to affect, but many times part of this work, we will see some return of investment. So we're looking also tracking at some of these things as a secondary effect of this work. And then the last one, we also wanted to have an understanding geographically, since we do cover a large area, to understand, especially when we're going to be working with transition of care, when patients are leaving the hospital, and to really understand where are they and where are they consuming, the resources once they leave the hospital. Next. So start very high level. We wanted to show part of our dashboard. We wanted to show the outcome measure. So here we're tracking the number of hyperglycemia and hypoglycemia rates. And so they will be able to have a trend line to be able to understand how they're performing against the average and a run rate. And also part of the dashboards is that some of the initiatives were being done at a unit level as opposed to the whole hospital. So the team was able to also to drill down to specific units if they needed to. Next. So these are the process measures. So you probably remember what Dr. Barnaby was sharing with you before about those two things about the implementation and solution that they were tracking because they had the lowest compliance in the process. So those are actually two things we brought into the dashboard so they could continue evaluating whether or not the interventions that they're doing for this specific process are changing. So here they'll be able to see it again. Very similar concept, the run rate, and be able to see any trend lines associated with those two things. Next one. Now, we also were looking for other secondary return of investments measures associated with this project. We're looking how, when you improve the care of these diabetic populations, do you have an ability to reduce the excess days? And what excess days means is pretty much, in the United States, we also use DRGs, and DRGs usually come with a specific set number of days for a specific DRG. So if you're successfully able to discharge the patient from the hospital below that benchmark that they have, that's how you're reducing your excess days. We were looking on how we're reducing our 30-day readmission. So if we're discharging these patients, are we successfully keeping them from coming back? So we're looking at those things. And also we're looking to see what was our customer feedback. We're looking for those patients that we were targeting in this process and whether or not part of those interventions with the education and other engagement that they're being offered to them, are we getting any feedback from them about the care that they're receiving? So this is the other part of other measures, additional measures that we were tracking as well. Next. And this one is more about our geographic distribution of the population. And these, we also wanted to understand very quickly what was our population, what was the density, what specific areas we needed to work with, especially as these patients were being transitioned back to the community. So we wanted to understand what were those counties in our catch area, and also be able to understand, the resources that we have in those counties and be able to connect patients with those resources after they left their hospital stay. But in overall, that was part of our journey in the various data visualization as we trying to incorporate, we started from scratch. We touch on many different ideas and concepts, and then towards the end, we were able to come up with a cohesive version of things that the team wanted to track and how we're able to provide the data and visualize it, for those needs. That'll be all. Thank you, everyone.
Thank you. So just in the last few minutes, I'm just going to describe. So it's a Northwell large health system. We're doing this pilot at one facility in our health system, but by no means do we intend to just let that sit in the one place. So central to a lot of the work we do is always kind of designing our solutions with an eye to dissemination and scaling, or scaling and dissemination as this slide says. So on the one pilot, just some early data on the effectiveness of this inpatient team. Overall, we've seen some reductions in rates of hyperglycemia. We're still working on better capturing some of the process metrics and working out. Again, it's a very iterative process, and as we learn, we make subtle changes to the team, and again, with an eye to dissemination. So this is just data from our pilot unit. As you can see, the average rates of hyperglycemia have dropped about 2%. We are going to take a more rigorous look at this. We have a biostatistician, PhD level biostatistician on our team, who's already designed kind of a pragmatic trial to evaluate our effectiveness and implementation outcomes. But this is kind of a quick glance at what's going on in that unit. Now, despite the fact that we're measuring the unit, we also have a separate team at Northwell centered around quality, and all the work that Juan has done has been kind of handed off to this larger team with an eye to measuring these outcomes across the system. So they've already created a separate dashboard using Juan's logic and code to capture rates of hyperglycemia more aligned with the federal metrics around these measures. So this is at the facility level. So Huntington Hospital is our pilot hospital. 5 South is our pilot unit, which was the data on the previous slide. And then the beauty of this is that now we can we can compare across all facilities at Northwell. So again, these data products are designed, they're very much an experimental and local solution to begin with, but we've always got an eye to dissemination and scaling. So with that, I know we have just a few minutes. We're happy to answer any questions, but again, thanks for taking the time to listen to us.
Thank you very much, Doug, Sherry, and Juan. This was very, very interesting. There's a question. How do you manage or prioritize CAPA actions based on data and make sure there's continuous improvement?
The CAPA actions, Sherry, is that a term you're familiar with?
Corrective and preventive. I wasn't familiar with the either.
No, it's a great question. And, you know, the beauty of this is that, as I said, kind of this learning health system approach, which we didn't have time to dive into, is that we have a team of probably close to 50 people that meet monthly to evaluate our progress and to look at our process metrics as well as our outcome metrics. And that's in addition to the smaller groups of 8 to 12 people that are building the solutions themselves. So as far as managing and prioritizing them, you know, we're very much an agile framework. So the teams identify features that they put in their backlog and prioritize certain enhancements to the teams and technical solutions. And that's kind of demoed monthly, and feedback from the community drives prioritization.
All right, thanks. Another question, how is the data collected and are there challenges associated with data collection?
Not at all. No, of course, yeah. We have, so
I can answer that.
You know, to make things, to put a fine point on this, we are currently going through a multi-year transition to a new EHR. Our existing EHR is admittedly not the greatest. Well, Juan, you can weigh in on this, but getting data out of our existing EHR requires somebody like Juan to dedicate a significant amount of time. We're hoping that the transition will improve access to data, but so the quantitative data, I'll let Juan address. The qualitative data is difficult. We have to go and talk to people and do a fair amount of rapid qualitative analysis or some deeper qualitative analysis. But again, it gives us unique insights that let us see the why beyond the what in the quantitative work. Juan, do you have anything to add there?
Yeah, no, one of the things is, you know, as more information becomes available in an EHR, the challenge, I don't think, is going to be so much about the collection of the data, but to be able to synthesize that data into insights. Just to give you a perspective about these projects, we're looking, you know, for every single time we were doing a test on the glucose level of a patient. We're looking at every time we were doing measuring that blood. So we're looking at medications, we're looking at lab, we're looking at diagnostics, we're looking at so many different data points. So usually the challenge that we now that we have EHRs, that information is available, but the complication is how are you going to synthesize that data? How are you going to take so much data that it's out there and make something meaningful and useful out of it? So things, you know, as technology evolves, I think some of the things as collection of data will be solved. As we have more integration of our system, some of those things just natively will be solved. But the challenges that we're going to see in the future is that, you know, how do we remove the noise when you have too much data and to be able to synthesize it into, you know, meaningful insights?
Right. Thank you. I don't see any more questions, and we have actually used our time already. So thank you very much for the presentation. And last, I want to thank all the presenters and also Tietojohtamisen Verkosto Association and the International Hospital Federation, and of course the audience. The recording will be later available in the member platform of Tietojohtamisen Verkosto Association and also in the Big Data Roadmap website of International Hospital Federation. Unless we had some technical issues there, so now when we're closing, we are just hoping that the recording will save itself. So let's have fingers crossed. So Merry Christmas and Happy Holidays, everyone. Thank you very much.